Welcome, everyone. Thank you very much for joining us. We have a great team with us today. We're going to talk about pharmacy and prior authorizations and a real specialty with a lot of nooks and crannies and nuances to it that everyone needs to know about. So before I jump into the topic, let me introduce our guest today. Derek Taylor is with us. Hi, Derek.
Hello.
He is our Senior Director of Client Services at Infinix, and let me tell you just a little bit about him. He's been working in pharmacy for 20 years. He started out as a technician while in college and worked his way through a biology undergraduate and then pharmacy school and received his doctorate of pharmacy. He's worked in long-term care pharmacy, both in clinical and managerial roles for 6 years. And he has over a decade working for Infinix Healthcare, overseeing all the pharmacy operations. So that's our pharmacy side. And then we have Jennifer Glockzin. Welcome, Jennifer.
Thank you so much for having me.
Great to see you. Jennifer is our Senior Manager of Patient Access at Infinix, and she covers scheduling, patient registration, insurance verifications, and prior authorization operations. And she's based out of our Houston office, and she's been with Infinix for 2 years as the manager overseeing prior authorizations after 20 years of experience in a provider's office setting covering multiple specialties. So you can see we've got both sides of the equation here. So let's just jump right in. So obviously, prior authorization, it's the first step in the revenue funnel. Done well, it can fuel a robust bottom line, but when the tasks start getting splintered, then revenue gets stalled and it's really not a good picture. And that becomes even more complicated when we're talking about pharmacy prior authorizations. So let's start by defining what we're talking about, the differences between medical and pharmacy prior authorizations. So Derek, can you start us off and describe pharmacy prior authorizations for us?
Sure. So if a prescription itself, a medication is being prescribed, they can be submitted as a pharmacy prior authorization. It basically comes down to if the service or the what's being billed is a prescription item versus whether it's a medical treatment or other sorts of therapy. So medical prior authorizations are most of what doctors' offices are prescribing for treatments or therapies or labs, those types of things. What's referred to then as pharmacy prior authorizations are the medications themselves, and they're billed through separate channels. So you're billing the payer through pharmacy agreements versus the traditional medical agreements. So most pharmacy claims are submitted, the prior authorizations are submitted through a pharmacy through their software.
Jennifer, when someone asks you to define prior authorizations, how do you define it?
So the prior authorization is just the initiation with the insurance company to let them know we plan on providing this service. In this case, it would be a particular medication, and getting that authorization from the pharmacy prior to providing the service, letting them know, letting the provider or the pharmacy know that the insurance agrees that they will then cover that service. And your basic difference between your imaging prior authorizations that are generally done by your offices versus your medication authorizations that are initiated usually in the first part by the pharmacy is that while both of them require great documentation, the authorizations for medications tend to require more in-depth documentation at the provider level in order to justify those authorizations.
Let's start at the beginning of the pharmacy prior authorization journey, so to speak, and kind of lay this out. So Derek, the patient sees the doctor, he or she prescribes a medication for the patient. Now what?
Yeah, so yeah, with the prescription that gets to the pharmacy, who then tries to submit the claim, as a pharmacy prescription claim. And At that point, you'll then typically get a rejection. When a claim, they're submitted in real time and the rejections come back in real time. So within, 5 or 10 seconds, it goes into the payer database and bounces back and tells you, hey, this particular medication requires a prior authorization. The details of that prior authorization and what would be needed, all that is not on that electronic bounce back. It's just a statement that, hey, this is a non-covered medication without a prior authorization. And so at that point, it then becomes a fun, long process of determining what needs to be done for that medication to be approved, what requirements would need to be met, going back and determining if that patient matches those requirements or qualifications, and then providing documentation to the payer of their qualifications and resubmitting it. And when that is done, then we can get that prior authorization approved for dispensing.
So I'd like to be as specific as possible for the people who are attending. And by the way, if you have questions, please just enter them into the chat and we will ask our guests to answer your questions as you ask them. So who is involved specifically? Like what staff positions are involved and should be part of a coordinated effort to get to successful pharmacy prior auth? So since the patient's sitting in the doctor's office, Jen, let's start with you. Who needs to be involved to get the right information started out of the gate?
So generally in most practices, what you'll find is once the pharmacy, like Derek says, runs the claim, they find out an authorization is needed. Most pharmacies will do one of two things. They will send a fax over to the provider's office, just letting them know this particular medication requires an authorization. They will generally provide the pharmaceutical benefit phone number for the office, or they will then upload, some of the pharmacies will then upload that request to Cover My Meds, which is the biggest platform that offices use to then process those authorizations. Generally, in most office settings, what you will have is you will have either a nurse or even a medical assistant who works for that particular provider, who will then go into the portal. They retrieve all of the necessary information. Generally, when authorizations are needed, it's due to a formulary step program within that patient's benefit plan. And that requires the medical assistant then to review all previous clinical information, previous meds that have been described, dosing, how long the patient was on it. So a lot of that is done generally by, like I said, either a nurse or a medical assistant who then has that direct access with the doctor who can ask questions if needed.
So Derek, what's happening on the pharmacy side? Who's involved over there?
Yeah, so because the pharmacies operate in their own practice management software and don't have access to the clinical databases, the initial role on the pharmacy side is more of a non-clinical one. So that being said, I'll talk a little bit today about defining formulary practices and collaborative practice agreements, which can help allow the pharmacy to do a little bit more of the heavy lifting and also avoid going down the pathway of requesting a prior authorization when it's really not gonna work. And so it basically while the onus of getting the clinical information and the submission in place falls upon the prescriber, pharmacies have tried to do as much of that heavy lifting as they can. So as Jennifer mentioned, we will first of all look at the medication, see what class it falls in, look at the formularies of the office or the medical practice. So for example, if we're working with a particular doctor's office that has their own internal formularies, we can look at it and see, well, the medication is being prescribed that's requiring prior authorization. Is there already a formulary in place with the prescribers where it should be changed to this medication instead, which we know will be approved and won't, that instead of trying to force a prior authorization on a medication that requires those kind of things. So with a lot of the general medication class, you can predefine those formularies in-house, separate from the payer formularies, and avoid, a lot of the prior authorization work, allowing the pharmacy then with that documentation to change the order, get the signature of the prescribers for the order change, and removing it from the prior authorization process altogether. So that's one, I think, the really helpful thing that the pharmacies can do. And then the other is if it is determined that this is a medication that we should move forward with getting a prior authorization, as Jennifer mentioned, we can go into Cover My Meds, or there's a few other, sometimes state-based websites, which are set up to provide that kind of communication and workflow in submitting the claim, where the pharmacy can populate all the general, set up the full patient profile, the medications and the strengths, and then it can select the correct form for the correct payer, and then push that forward to the prescriber's office, where then the nurse and assistants and the staff there are able to then go in and only have to fill in the clinical information, which may be, including labs or confirmation on different requirements, and then push that claim forward to the payers. So that's what the pharmacy can do on their side.
So the other leg of this three-legged stool is the payer, are the payers. Jen, can you talk to us about the payers and what's happening on their side? We know from other people, the requirements are changing rapidly. They seem to be squeezing, the bar gets higher and higher. So what's happening with pharmacy and what physicians want to prescribe for their patients?
Yeah, so the formularies, every insurance company, like I said, you have the medical insurance company, so maybe Blue Cross or United Healthcare. Their insurances for their pharmaceutical benefits generally fall within a different company. So you've got Prime Therapeutics and several other different companies that offer the benefit coverage specifically for medications. What you do see is insurance companies tend to update their formulary yearly. So from year to year, that formulary and what they call their step therapy changes from year to year. So every year you start out the year, it's kind of like a work in progress. You have to figure out what that baseline, because all medications are tiered. So you've got your initial tier 1 drugs. Those are generally your generic medications. You go up to your tier 2 drugs. Those are the name brand medications. And then your tier 3 tend to be those newer medications that have come out within the past year or two that are still pretty expensive for the insurance companies to pay out for. So that's why they generally like patients to start on those generic medications, work their way up. So those do change on a yearly basis. And what the step therapy is for one insurance company may not necessarily be the same step therapy that you're going to get with another insurance company.
This may be too broad a question, but it brings to mind every specialty has different drugs. Like certainly an oncology practice is going to have many more emerging drugs that they want to choose from, whereas an orthopedic practice may have tried and true drugs. And I may be getting ahead of myself, but it reminded me of the question. So what exactly are practices supposed to do when they want an emerging drug for their patient, but they know it's going to be a tough road to hoe? And I'd like both of you to answer, please. Jennifer, why don't you start from the practice side, and then we'll go to the pharmacy side.
Sure. So from the practice side, most of the time you want to start with a generic medication, a medication that's been out there. Generally, what you're looking at, most insurance companies want to see a 30-day trial and failure of any of the drugs within their tiered program. So generally, what a lot of doctors will do, if you have the time with that patient and their and their care, you want to try a generic medication, give that a trial for 30 days. If you're not seeing the improvement desired, then you want to step up to those name brand medications. Now, you do have some medications, we're seeing a lot of them now coming out for, like you said, oncology. You see a lot of new drugs coming out for the diabetic care for patients with type 2 diabetes. So what you really want to do is, if you're in a position to where you don't have the time in order to work that patient through that step therapy program, you just need to make sure that you have really great documentation in the provider's note, just documenting why they are not wanting to try these medications, why they feel that the name brand medication would best benefit the patient, and just make sure that that documentation is really firm on the practice side.
So Derek, it goes in the door of the pharmacy, and what happens?
Yeah. So kind of to expand on that last question. So if you have a very specific medication, a new medication that's cutting edge for a very specific disease state, and you feel that your patient is a candidate for it, and looking at the other generic or name brand lower tier options is not available, it takes us into the realm of what typically becomes specialty pharmacy, and it has a unique role in these very specific high end medications. Basically what happens is the manufacturer themselves is involved in that implementation and process. And so they contract typically one or two specialty pharmacies only to oversee that process. So while, as a prescriber, most of the time you'll be going through either your in-house or your default pharmacy. In this case, you would contact the manufacturer of the medication, and they would put you in contact with their team who works with a pharmacy. And what those guys do is, rather than just, jumping on board with getting a prescription and trying to dispense the medication, they will do a robust vetting ahead of time, because they specialize on that one medication and they're doing it for a large group. They already know what the requirements are for the different payers. And so on the front end, they will do an assessment and say, okay, this is the insurance that you have, this is your diagnosis. In order to do this, you will need to have tried and failed, XYZ medication, as like what Jennifer was referencing. So basically, you'll find that divider where, if you're a prescriber and you find a unique case of a new medication that really looks like it's the only real candidate, that would be the next step in really getting it successfully for your patient, is by then reaching out and going through the specialty pharmacy route.
We have a cross section.
But
Yes, absolutely. So we have a cross section of practices with us today. So Derek, share with us, what are some of the most common pharmacy prior authorization requests that you see?
Okay, and this is, I'm hoping as I answer this, this will be helpful in really delineating when we should proceed with a prior authorization request and when we should not. So basically, the prior authorization function, the desire by the payers, is to have this, make sure that the patients are not paying more, and the payers paying more for a medication that's very similar, right? That there are other medications that are less expensive, that have been used longer, that there's more data on, that are, basically what we refer to as biosimilar. They're in the same drug class, they work the same functionally. They are different chemicals, but very, very similar. I mean, think, like cholesterol medications, there's, how many statins, or, ACE inhibitors for blood pressure. There's these classes where you could take 5 or 6, and they're very, very similar with regards to safety and efficacy and that kind of thing. So anytime that you're requesting a brand name item or something that's new, that the patent's still there where they're not able to produce a generic, the cost will be significantly higher, right? And so that's the most common. Well, I'd say the most common is something like that, where you're requesting a medication where there's a biosimilar that's on their formulary that they basically require you to have tried and failed, one or multiple biosimilars before they'll even move forward with the prior. And then you'll see some prior authorizations that come across, but they're flags based upon the strength of the medication that's being prescribed, the frequency, the age of the patient, the diagnosis. Basically, it's a if the amount prescribed, the frequency, the details of the dispensing are different than the patient demographic. So think, like it helps flag for pediatric doses. It helps flags for, there's medications that we give, for example, you can, UTI, you can take an active antibiotic, twice a day for 10 days, let's say. But you can also take that same antibiotic once a day as a prophylaxis that you'll do indefinitely for someone who has had recurrent UTIs and they're a candidate for it. So sometimes it'll be like, hey, you're only giving this once a day. You need a prior authorization for that, or you're giving it longer than the duration that normally is given. We need a prior authorization for that. So, and then drugs for very specific indications. So when medications come out, they receive FDA approval on specific uses. But sometimes there's secondary uses that have some good data sets, and as a prescriber, you're interested in using them for an off-label use. It's legal to do that, but some of the payers will flag that as a prior authorization. Like they'll look at the patient profile and say, the patient does not have the condition that on profile that medication's approved for on the FDA. So to use it for an off-label, they might do a prior authorization. And then, basically, what this leads to is, I want to just talk for a moment a little bit more about what these formularies or collaborative practice agreements can do. So if you want to avoid a lot of this, you write for a particular cholesterol medication and then, you're having to change it. And, or you write for a particular, ACE inhibitor, and then the formulary only allows this one. And there's this kind of, automatic back and forth that's wasting the doctor's office's time and delays dispensing. Ideally, the physicians would be able to know on the front end, okay, for this payer, for this indication, this is their tier 1 medication. But their formularies, there's so many payers and there's so many formularies, it's impossible for doctors to really stay on top of all that, right? That's an unrealistic expectation. And so to basically get these little common, simple changes in place without without bothering the prescribers, you can set up either one of two ways. So you can set up your own internal formularies with collaborative practice agreement. So for a particular office or for a hospital or for whatever your prescriber group is, you can say all the physicians in our group, if they write for these medications, the pharmacy can substitute and get a drug change for these ones, and they'll have the strength equivalents defined as well. And so when the pharmacy gets that, they, instead of sending back hey, by the way, this is not covered, you need to change it, they're able to instead change it to what the preferred medication is for that institution. Similarly, on the long-term care pharmacy side, so where they're working with a lot of different prescribers and all these different doctors' offices, they can set up individual collaborative practice agreements with those doctors. And similarly, like there's just 3 or 4 major drug classes that you can set up these standardized interchanges. I've seen this even be effective and helpful on hospice, where you have transferring between different medications and trying to get dose equivalents, to have some of that predefined and allow the pharmacy then to instead of just sending it back and needing that intervention, be able to make the appropriate change and submit it for signature and review. And so I definitely recommend that if you are in a practice where there's just a lot of prior authorizations coming back for these general common drugs, is to look at setting up an in-house formulary or collaborative practice agreement on those.
Like that would streamline a lot of work and save a lot of problems, but it also brings me to my next question, which is to ask Jen, what are the most common problematic authorizations that you see coming out of practices?
Yeah, so what you see coming out of practices, you see a lot of injectables. So a lot of patients who have testosterone deficiency for their testosterone injections. You've got a ton right now coming out for, like I said, a lot of the new injectable diabetic medication. And just to kind of touch back on something that Derek had mentioned, what I've seen a lot of with a lot of the clients that we work with is a lot of doctors who are prescribing some of the new injectable diabetic medications for weight loss. Now, like Derek said, when medications are FDA approved, they're FDA approved for certain conditions, and some of them tend to have really great side effects. Like for a lot of the new type 2 diabetes injectable medications coming out, a really great side effect of that is weight loss. And so offices know when you have a patient who is type 2 diabetic, a lot of that can have something to do with the patient's weight. So if you can drop the patient's weight down, you get their glucose levels down, you get their hemoglobin A1C down, and that typically tends to work really well for the patient. But we do see a lot of doctors who are then prescribing these medications. And then when the prior authorization is done, of course, if the patient doesn't have type 2 diabetes, they're using, weight loss as the diagnosis, or weight gain. I mean, you see it kind of come all kinds of different ways. Another one that we see a lot for is something as simple as test strips. For the diabetic machines, a lot of doctors prefer either freestyle, or maybe they have a rep come who drops off a specific type of diabetic monitor. And then what you see is you get a lot of prior authorization requests for the test strips for that particular monitor. And rather than spending your time trying to authorize the particular one that the strips for the particular machine you provided that patient, it may be more effective and for your staff and time to order a machine, or have a rep drop off a machine that is on that patient's formulary. But again, we're seeing a lot of medications coming out, or a lot of PAs coming out for these new diabetic medications, for the injectables. And like Derek said, where an insurance company their preferred drug may be Lipitor, but you want to prescribe the patient Crestor due to the way it affects the HDL and the LDL. Those types of things will require authorizations.
Interesting. Thank you. We're almost out of time, believe it or not, but I think we need to quickly move to advice. This is certainly a very complex issue. And so, Derek, let's start with you. What advice do you have for practices to make pharmaceutical prior authorizations more successful?
Yeah, so I think it's, if you have a large number of prior authorizations, obviously it depends on the types of patients that you're treating. But if you find yourself getting a lot of them, look at the standardized, what types of prior authorizations are you getting? And are you finding yourself doing a lot of those switches where you're switching between biosimilar generics, to coordinate with your prescribers and your medical group, or if you're a pharmacy, coordinate with the doctors, your most common doctors, and get a collaborative practice or internal formulary agreement in place. I think that can for a lot of these cases, I mean, it'll reduce your prior authorization load in half. And a few other things is, recognize when you're not going to be able to get a prior authorization on a medication, right? To not go down the whole process of submitting or prescribing. If oftentimes you'll find doctors, will have drug reps come and, giving them the information on this next great new medication. But recognizing that the likelihood of them, being paid through the payer without a prior authorization, or even with a prior authorization without having gone and tried and failed other ones, is not very likely. And so, keeping that in mind, just kind of being cautious with regards to, what drug reps or new medications come on the market with the likelihood of payment. Obviously, all of these medications, if the patient's willing to pay cash, great, right? But obviously, that's not what we see most of the time. And so, kind of developing those processes and having a really clearly defined roles of the pharmacy and the doctor's offices and the prescribers there. At the end of the day, the most expensive are your clinicians, those prescribers, their time. And so make sure that all of your clinical work is being done by their agents. So nurses, office staff can populate and provide that clinical information on behalf of the prescriber, and then the prescriber can just review and submit it. Make sure that that's what's happening, that your doctors are not stuck in there, digging up and populating prior authorization forms, because that'll just, that's obviously very expensive. So those are some of those best practices that really can minimize, how much time and delay and investment you put into getting these prior authorizations.
Would you add to that?
Yeah, so I was just going to say, from a provider standpoint, I think really the best advice that I could give, it's all about communication, right? So what you want is the providers, their biggest part in the prior authorization process, again, is just the documentation. If you're prescribing a medication that is either new to the market, you would rather the patient use the name brand as opposed to the generic, or any other medication that may be on the formulary, what you want to make sure is that in that documentation, because even when the clinical staff is submitting these prior authorizations, a lot of them do require that we submit clinical documentation. So just making sure that, the providers make note of, patient previously, took atorvastatin, it, wasn't effective. We moved patient over to Lipitor, that was not effective. So now we're requesting, that the patient, try the Crestor. The communication also with your drug reps. You do have the drug reps who come in and they want to really push these new medications. Like Derek said, a lot of these companies have things set in place. Some of them even have forms available to help you along with that prior authorization process. So that communication then with the pharmaceutical reps, and how do we combat when prior authorizations are required. And then there is that one key component, particularly when providers are seeing new patients. I tell a lot of people, patients are actually more likely to change their provider than they are their pharmacy, right? Because pharmacy is chosen based on a location. I want to use the CVS because it's around the corner from my house, right? So a patient may switch their provider when they come in, they're seeing a new provider, they decide we want to provide this specific type of drug for the patient. Then to have that communication between the doctor's office and the pharmacy, where the office can reach out and say, hey, we've got this patient, they're new to us, we're going to be prescribing a certain medication. Can we discuss with you the patient's medication history, something that the pharmacy would have on file based on what they've dispensed? So it really just comes down to great communication, both between the provider and their staff, the pharmacy and the doctor's office, and then all of that then can be being communicated back to the insurance company. So just to make sure that the communication is clear and concise, and that you have everything that you need in order to obtain that authorization.
So before we go, we do have a question. I'm not sure which one of you wants to attack this, but the question is, we have patients who listen to television advertising, and they come into the office and they request a specific drug. We have no idea if it's going to be covered. What's the fastest way for us to find that out in order to answer the patient's questions, which can be quite insistent?
So
Which one of you would like to attack that?
So that is something that you see a lot. Spending 20 years in doctor's office, it never fails. And a new commercial comes on and they're blasting it on every channel. And so the patient listens to the, all of the symptoms list, and they're like, oh my gosh, I have all of that. So this medication must be for me. So from a provider standpoint, what I would suggest is letting the patient know, this may be a possibility for you, but due to it being a new medication, the insurances may not be covering that particular medication. That is something that the provider staff could, depending on how big of a patient volume you have, and how much available time your staff has, you could reach out to the pharmaceutical carrier and ask them if that's a covered drug. But I think the best way to attack this and to save the best amount of time is for the prescriber, to maybe explain to the patient, it is a new drug. It's going difficult to get covered. Let's see if we can find something that is similar but more cost effective for you that your insurance plan will cover. And then if that doesn't work, then, we push on to that type of drug. So it's really just patients are going to see what they see on TV, and it's going to sound really great, but then it is up to us as those that clinical staff, that medical provider, to then really guide your patient that things that are bright and shiny and new may not always be the best answer for that patient, either medically or cost effectively.
Eric, you must have seen this a lot in your experience.
So and I think one other point. I mean, that was a great explanation. One other point is you can also put this back on the patient to call their insurance. So most payers are very like you can get your payer on the phone within minutes and ask about, hey, I want to see what if I'm prescribed this medication, what will it require prior authorization? What would my copay be? Because ultimately, if you move forward and write the prescription and send it to the pharmacy is going to submit it. It's going to come back as saying it needs a prior authorization. And then there's going to be that big delay of tracking down that information. But the patient's entitled to be able to call and get that. And they can get it while they're sitting in their office, right? So, I totally agree that setting that expectation to the patient, hey, this is a new drug, but, it's very expensive, it's name brand only. And, most of the time the payers won't cover it. But contact your payer and see, right? Call your insurance card and ask them what their coverage is on it, or what would be required to get a prior. And then you're not the bad guy, right? Then it's the insurance that's, they're the ones setting the formulary. They could be the bad guy.
Right. Great advice. Well, thank you so much to both of you. We could do another 3 sessions on this topic. Time just flew by. Thank you for your expertise and sharing it with us. We greatly appreciate it.
Thank you so much, Deborah.
Yeah, you're very welcome.
Yeah. Thanks, everyone. Have a great day.
You too.